just start, and I'll be speaking regarding the complex tibial plateau fractures, which involve both the condyles as well as the soft tissues. And I'll be taking you on the entire journey regarding this proximal tibial fractures and how the situation has changed over the time, over the last few years. We'll see through various set of cases where and how we are nowadays planning our surgery and how we are making sure that the results are getting better and better. So we all know the Schatzker classification, and what we are going to discuss now are the 4, 5, 6 fractures, which are the most complex ones, with the unicondylar lateral plateau fractures being relatively simple with just putting in a unicondylar plate. As per AO classification, if we look at these fractures which are completely articular and have both the condyles which are involved come in 41C. The first thing in any proximal or any fracture for that matter, what we need to understand is it consists of 3 components: congruity, stability, and alignment. And that's there for any and every articular fracture. And if you see, all of them are equally important in the articular fractures and which give good functional result. If you look at the proximal tibial fractures, the congruity part remains the same. However, the stability as well as the alignment part, they are much, much more important than what we see in the normal articular fracture. So that defines the goal of treatment for us, which is the first and foremost, the restoration of alignment and length, stability of the knee joint, and finally the anatomical reconstruction of the articular surface. So you can see that there is slight change in the goals. The articular component is slightly lower, whereas the alignment, axis, and the stability takes a priority in proximal tibial fractures. This is also because the articular component is thicker of the proximal tibia, and which can withstand a lot of wear and tear as compared if the limb axis alignment can be checked, it will stay. So let's go on our journey and see how the things have changed, and I'll show you various patterns of type 4, type 5, type 6 fractures and how we decided of where to put in the plate, how much to put in, and when to put in. We all know type 4 fractures are high energy, which is medial condyle, probably and mostly related with dislocations, and the ligamentous injuries can be there. And most of them require a unicondylar buttress plating with a lag screw. You just cannot put in lag screws because the shearing forces are pretty high. So remember that if you have a proximal tibia type 4 fracture, ideally it should not be fixed just by anterior to posterior screws, and you require an anti-glide plating because that is going to give you good forces to resist the shearing forces which are affected. So let's see this fracture. You see this is the common proximal tibial type 4 fracture, having a dislocation along with sometimes a distal neurovascular problems also. Always and always check for the vascularity in such cases because it might be a problem. And the amputations which I have seen in my experience are majority of them in this fractures are type 4. So here what is to be done is that you reduce these fractures, and if you see the CT scan, it's sort of a vertical fracture line in the eggshell plane. So your plate can be dead medial, or if the rotational element is there, it can be you have to lag these plate in a vertical fashion. So that's what has been done here. You have reduced them anatomically, and then the 2 screws are going in at perpendicular to the direction, and after reduction, the posterior displacement of this fracture pattern has been connected with the plate. There were 2 planes out here. One has been fixed with the screws, and the second one reduction has been done with a plate. And that's what you get, a reduction which is anatomical from the medial side and excellent results. Another type 4 fracture. Now you see that the CT scan shows you that the fracture pattern has slightly shifted posteriorly. The angle of this fracture has gone posteriorly medially. So your plate has to be somewhere on the posteromedial part not dead medial out here. Hence, this is what has been done. A medial plate and a simple non-locking plate has been put here because this is a unicondylar fracture. And you can see the results, they are good with good union. Even the tibial spine, which was left as it is at its place, has united, giving you good results. The third thing is these fractures. Again, you see a type 4 fracture, but how the CT is helping us to understand which is the fracture site, which is the plane and the apex of the fracture, and where to put in the plates. Here now that fracture has shifted dead posterior. You can see that the plane has become coronal in front instead of sagittal. And that's what now your plate also has to go dead posterior for this. So that's how you do for the type 4 fractures. Look at the CT scan, not just at the X-ray, because X-ray picture will look the same in all the cases. However, the apex of that fracture fragment will differ, and the plate has to be put exactly parallel to the fracture so that the screws can go perpendicular to the fracture plane. When we come to the bicondylar fractures, they are high energy and associated with soft tissues and metaphyseal considerations. We know that these are the four things which always problem creation is there and which create problems like timing, approach, reduction techniques, and how many plates. And I'll show you how the trend has now shifted over the years from just looking at the X-rays to CT. The CT fracture fragment is going to decide which is your approach, how you're going to put in your plates, and how the fragment specific fixation is going to be done nowadays. So if you have a bicondylar fracture like this, you understand that you are going to put in a plate. And normally we used to put in the question which comes is, can we fix this with a single plate or a dual plate? So this was the fracture which was fixed. And now you see after 6 months, this is my own case. And this we see it has gone fixed, united, but in varus position. And that is what we published also in IJO in 2015, where we compared a single plate with the dual plates. And we found that the dual plates and bicondylar plateaus were giving us good results or better results as compared to single plates. With that premise, we continue further and see how the soft tissue considerations are affecting us. So the questions which come to us is what to do when we have fractures with blisters and soft tissues like this. And the things are that we have to wait for healing if we are planning for definitive fixation. You just cannot go in with this, otherwise you will have lots of bad results going in for amputations. So this is what you do during that time. You span the fracture by a fixator if there is a lot of displacements, and then scan it to understand how the fracture can be fixed. And here comes the Luo classification or the CT-based classification. There are multiple classifications which have come up over the years on the CT-based. And what we need to understand it is axial pattern which we look at, which decides which is the fracture which we can fix and how many plates and approaches can be taken. The questions which come in our mind is how to delineate the fracture fragments, which is through CT scan and axial cuts at the level of fibular tip. Which fragments required? Again, it is the CT classification which helps us. Which approach to use? We use normally the anterolateral in combination with other approaches, and how many plates. And here comes the fragment specific fixations which needs to be taken care of. Just showing you how over the cases we will see that CT decides and we will decide in this journey which plate to be put. This fracture pattern looks same, a very similar standard fracture pattern. Now we look at the CT scan. What we find is that the fracture is vertical. So a plate from this side and from the lateral side is going to suffice. And that's what has been done. You can see both the plates are at opposite directions, medial and lateral, and we have put in these plates. Next comes a similar sort of a fracture which we see, but here the configuration of the CT based, what we see in the CT is that the fracture has shifted posteromedially with the apex going posterior. So a similar fracture or like this needs fixation or a plate from the posteromedial side and an anterolateral side. And that's how we decide. And you can see that the same sort of a fracture is fixed with an anterolateral plate, but the medial plate has shifted posteromedial. Now comes another CT, which is showing us a CT. X-ray is again the same. The two lateral view looks the same in most of the cases, but it's the CT which helps us to define where the plate is going to be. Now you see the CT scan, you can see that the fracture fragments are coronal dead posterior. And that's what we look at, which is not visible here or here, which exactly to go in for. So what do? Since there is no anterior fracture, we go prone in here, do a standard posteromedial Lobenhofer approach and fix this fracture by reducing it just like a Wöhler-Barton fracture of the distal radius, and two plates have been put here and a screw fixing the lateral side. And that's what is the follow-up and the results of this patient. So what we did, we wanted to fix this fracture from the posteromedial, lift up this and put in a plate or reduce this with the lateral posterolateral, and this we did both from the same approach. So what is the surgical plan? Whenever you fix the medial fracture first, plate as per the fracture plane, prevent the varus, put the plate at the apex, and that's what we go about. You can see that we are trying to reduce this fracture. The medial column has been properly reduced. Once we reduce the medial column, then the medial plate is being applied. Once you put in the medial plate, then you put in your lateral plate and your raft screws, which are holding the articular fragments in the complete anatomical position. And that's the complete final picture which you get once you have reduced the bicondylar fractures. Let's go for another case. You can see that now it is a multiple fractured area. And how do we look at, we are having 3 or 4 fragments. So where exactly you see this CT scan, you can see that there is a major fragment of the medial side, posterior side, anterior, and the anterocentral part. So again, this has been fixed through a posterior approach first, making sure that we are taking care of the medial and the posterior fractures. And then we have shifted to a lateral approach and fixed it in this fashion. So first, the medial side, the posterior side is being fixed. Then after fixing this, we are lifting up the lateral part. And once we have lifted up the lateral part, then the raft screws are going in. And this is the result which we get. So finally, there are 3 plates with an anatomical lateral view, which you can see having good articular congruity. Alignment has been maintained, which is the foremost. And this is his follow-up X-ray, which you can see that the things have united in a very nice outcome functionally as well. We are going from posterior, anterior, medial, and now we go anteriorly towards the medial side. Now this is a fracture pattern which is of late coming quite often, where you see that it's the anteromedial part which is getting the depression. Just like a lateral, we have the anterolateral depression. These are the new ones which are coming, which is an extension, hyperextension, varus injury, where you can see that this appears as if it's a lateral part of depression. It's not. This is not the lateral part, it's the medial depression of the anterior part. And that's what we try to do. You lift up from the medial side. You see how much gap can be created once you correct the varus out here. Once that varus has been corrected, then the slope of the posterior tibia has to be recreated. And once we recreate that, we are doing and taking care by a rim plate, taking care of that fragment, and a small distal radius plate holding these fractures. Most of these fractures have a lateral collateral injury as well, or a ligamentous injury, which has been fixed here because it was broken on the top. And that's what we have done. A rim plate along with a anti-glide sort of a plate holding the anteromedial part of your medial condyle. Sometimes you have these soft tissue conditions in a type 6 fractures. So once what we do here, we wait for them, get the CTs, and then finally we go about fixing them if we have to do with the plates and get good functional outcome with them. Here, hybrid fixators also come into place. And if you have a fracture similar type 5 or type 6 fracture and such a horrible looking things of the soft tissue condition, which you know that is not going to improve even later, the best thing will be to let them subside slightly and then get in and do an Ilizero fixator, because as I again say, length alignment axis is more important, get the articular reduction, and finally get good articular congruity as well as the alignment in such cases. From the medial side, we come to the lateral side. And if we see lateral side, we see that now everything is now CT based. And if in the CT, you can see posterolateral and anterolateral fracture fragments here, which needs to be taken care. So how you can do that? You can do that with fibular osteotomy. Here the osteotomy has been done and then this fragment has been corrected. This plate has been put posterolaterally here, a small plate, and then subsequently the reduction has been done and maintained here. Another case, the X-ray shows nothing. You can see that many of them will pass by and you will not have anything to see by. But if you look at the CT scan, the anterolateral as well as the posterolateral parts have totally gone. And this part is totally going posterior as compared to the articular side. So again, a fibular osteotomy can be done, and you can see how these things can be brought back into its place. And subsequently, this can be got with excellent and good results in such cases. Similar case of posterolateral as well as anterolateral side, you can see lots and lots of displacements. And these are very common nowadays, getting to when you see the CT scan, posterolateral and anterolateral side. How you go about fixing them? Again, you can go through fibula or through Frosch approach and subsequently fix this from both anterolateral plane and a posterolateral plane posterior to the fibula without osteotomizing it and putting in both the fixations. So over the years, if we see, this is our latest paper in JCOT where we see and showed that the CT scan has totally changed. Over the last 5-10 cases, what you have seen is the X-ray picture is not the one which is showing us how to manage these fractures. It's the CT axial cut, which is telling us how many plates might be required. How do we fix those fracture fragments? And here, out of 53 cases, we found that when we do CT-based fracture-specific and fragment-specific fixation, we get good results. So in the end, I would say that always and always anatomically understand first what you are dealing with in the fracture morphology, which is to be CT-based. The surgical approaches we all know is the posteromedial, posterolateral, and the introlateral part. They can be decided based on which are the fractures which are there, what are the planes that we are dealing with. Remember that column specific or fragment specific fixations, which are big fragments, they help us in getting the stability, which is much more important in the knee, especially the proximal tibia, as compared to any other articular fracture. And preoperative planning helps us in avoiding surgical mistakes and improving our outcomes. I thank you for the patient hearing out here.